पळय ताजी मरे वय आसा 45. ह्या वयाचेर भुरगें तर जायत ताका कितें जाल्यार केन्ना केन्ना मंद बुद्धीचें बी जावंक शकता कितें. सो ताज्या खातीर तुका कितें गॅरंटी आसा की चलोच जातलो म्हणून? मागीर कितें करतलो? भुरग्याक प्रॉब्लेम असो न्ही, पूण भुरगें जावन ह्या वयाचेर मातसो कठीण जावंक शकता कित्याक ताचे एजी खातीर. हां ताका ताची एज 45 न्ही, सो 45 वर्सांचेर भुरगें जावप हें मातशें त्रास आसता कितें. सो ताज्या खातीर तुका स्पेशल ट्रिटमेंट करचो पडटलो. म्हणटा तुका कितें गॅरंटी आसा की चलो भुरगोच आसतलो म्हणून?
तशें सांगूंक
मागीर
तें नशिबाची.
कितें करुया गो? तुका खर्च येतलो, जातलो तुका तितलो करून खर्च भुरगें जावन?
कितलो कसो येतलो?
1 ते 1.5 लाख रुपया येता.
एका
हम्म.
ना जाल्यार शक्य ना तशें. चड पयशे खर्च जातलो. आमी रोजगार काम करतलो.
मागीर क्या करें?
अशें हेजेर जावंक शकना.
कितें?
आतां म्हणजे हे बाकी सगळे बरे आहा ते तशें जावंक शकता काय म्हणटा.
म्हणजे कळुना म्हाका.
तशें म्हणना आतां
रिपोर्ट बरे आसा.
रिपोर्ट बरे आसा न्हू.
रिपोर्ट आसा बरे.
तशें जावंक शकता.
जावंक शकता पूण गॅरंटी हांव दिना. कितें सांग की जातलेंच म्हणून. हांव ट्रिटमेंट दिवंक शकता तुका. कितें ट्रिटमेंटाचेर तर धरलें जाल्यार बरें आसा.
तशें म्हणटा हांव.
ओके.
हे अशें आमकां तुमचे कडेन जावंक शक्य ना न्हू तशें.
तेच पूण तुका ती गॅरंटी ना की तें मागीर चलो जातलो काय चली जातलें.
तें न्हू तें सोडून दी न्ही.
ओके.
तें नशिबाचें.
ओके. सो हांव गुळयो तुका बरोवन दिता. त्यो घेवनी ताका. कितें आनी त्यो घेतकूच मागीर अंडी बी कशी तयार जाता ती पळोवया. कितें ताजेर मागीर प्रेग्नन्सी धरता काय ना ती पळोवपाची. कितें रे? सध्या ही ओवाफॅम प्लस म्हणटा ती गुळी आसा. ही एक सकाळी च्या घेतली काय एक रातचे जेवले काय चालू दवरपाची. PPH म्हणटा ती गुळी आसा ती एक गुळी आज रातची आंगान भितर चलय. कितें भितर घाण आसा ती सगळी उचून दी. कितें गो? ओविफर्ड म्हणटा ती एक सकाळी एक रातची घेवपाची. कितें आनी सायफीन म्हणटा त्यो 5 गुळयो आसतल्यो. आयच्यान डेली एक एक रातची 5 दीस घेवंक जाय. कळ्ळें? कितें म्हाका येवन आज तारीख कितली 14. 14, 15, 16, 17, 19 कितें म्हाका 20 तारखेक हांगा परत येवन मेळचें पडटलें. ओके.
20 तारखेक येवपाचें.
येस बरें. आनी गुळयो सारक्यो आयच्यान स्टार्ट कर.
आयच्यान सगळेच स्टार्ट करता.
सगळ्यो बरें
सगळें आयच्यान बरें.
आज रातची ती एकूच गुळी आसा ती आंगान भितर जाय. कळ्ळें? ओके. Come. Good? Yeah. Hello? 400. जानेवारी. हाँ
बापरे म्हणटा 26 जानेवारी झेंडा चडोवंक लावलो.
थायरॉइड चालू, कॉर्फ्लोरा चालू, इस्ट्रोफड बंद केल्या तुझी न्ही? येस. उ शुअर एम हय मुगो दिसाक 3दा हां अल्ट्रा मॅग्नेजियम हां लुपी हिम कितें इकोस्प्रीन हय मुगो डुफास्टॉन दिसाक 2दा हां ट्रायडा प्रत्येक महिन्याच्या 1 तारखेच्यान 4 तारखेक हां आणि प्रोनाइन इंजेक्शन
ते विकान
वन्स अ वीक हें चालू दवर कितें आनी मागीर आज तारीख कितली आज तारीख 14 18 तारखेक येवन दाखय म्हाका 18 न्ही बेगीन यो मातशें 9 तारखेक
डिसेंबर
हय
डिसेंबर
हां ओके
ओके
ओके उदक मात पिया भरपूर येस
पॉझिटिव्ह येईल प्रोडक्ट
गुड बरा
आणि ते हे घालता मी जेल ते त्यावर तिथून मातशें
ब्लॅक कशें
जाता
लागता
न्हू
दॅट्स ओके दॅट्स बरें ओके
आतां हे पासून म्हणजे जाता खूप पाशात
ऑल द बेस्ट
ओके
ओके रेस्ट दी ताका सारको बरो
तेजूय इंजेक्शन घेता
हां हां मागीर 15 दिसांनी आपयला दिसता ताका मरे
22
हय
त्याच्यात कितले कितले ते बरयल्या डॉक्टर म्हणजे
ओके
ओके
येस ब्लड काढलें टीटीचें करून घे आज ओके आनी गुळयो खंयच्यो घेता
एकूच दिला म्हाका म्हणजे सध्या
आनी
आनी काय ना
कॅल्सिमॅक्स 1000 म्हणून गुळी आसतली ही डेली एक एक सकाळीं घेवपाची फॉर एक्सटी म्हणटा ती दनपारां इकोस्प्रीन नाजाल्यार डेलिस्प्रीन म्हणून गुळी येतली कितें ही रातची आनी ताज्या बरोबरूच मिशेल SR 200 म्हणून गुळी येता रातची घेवपाची
ती चालू करपाची
ती बंद केल्या आतां काबार जाता तुका आनी घेवपाची गरज ना आयर्न कॅल्शियम
आणि
आणि रिपोर्ट
एक रोज बी
बरो आसा सगळो रिपोर्ट येतकूच म्हाका हाडून दाखय ब्लड
रिपोर्ट.
टेस्ट जाल्ला
हांगा 2 दिसांनी म्हटल्यार थंय 10 दीस म्हटल्यार
हय सो 10 दिसांनी डायरेक्टली येवन दाखय ओके
सो ते रिपोर्ट दवरतले
Yes.
कितें
ओके
डॉक्टर आतां
कितें
कितें तें कळटा
रिपोर्ट येवनी मुगो मागीर पळय ओके
तशें
हां इतल्या बेगीन जाय
तशें जाल्यार कांय करचें
That's
ना बस
तीन हे आला तीन
तीन क्रॉस जाले
हम्म.
तीन क्रॉस जाले
चवथो चालू आसा
आणि ट्रॅव्हल केल्यार जाता काय प्रॉब्लेम नाही पण म्हाका 10 मिनटाची वाट गाडी जाल्यार हाडपाची जेव्हा तरी
ओके
Nelson to present his views.
या
time of your busy schedules to thinking is Juan Garcia Velasco, Professor Velasco, has very clearly outlined the value of AMH in women of younger reproductive age. And what we want to now think about is how we can use that in the older women across their lifetime so that you can still see.
ओके ही गोळी आयच्यान सुरू कर दिसाक 2दा 22
Because what I would suggest to you
ओके
is enter our clinics. We've already heard about Cindy and how she's 29 and she's wanting to wait to find out how long she can have children
पेशंट
for.
पयली पोंग जाय तुज्या तेनी म्हाका पयली
But we also have people who are worried about menopause. And Susan, both her mother and her sister had premature ovarian insufficiency, and she's worried about whether or not she will get it. Jillian, who's 32, she had breast cancer and she's had chemotherapy, and she's now wondering whether or not she will also get premature ovarian insufficiency as a consequence of that chemotherapy. Mary is starting to have irregular cycles and is wondering how long will these continue before she goes through the menopause. And then Jean is 51,
कितें बरयलां
but she's not had any periods for 6 months, and she's wondering whether or not she's menopausal or not. But the problem is, as you know, we can't actually define menopause until she's at satisfactory for Jean. She's got to wait even longer before she can get that actual diagnosis. Women change across their lifetime, and then think of the number of follicles they've got within their ovary. Well, that's going to decrease and decrease exponentially. In contrast, the genetic variation
मागीर एक काम कर यो 10 वर कितें
time, there may be slight epigenetic.
5 वर आणि ही 1 वर हां मागीर येवन आनीक बर
And so when people have looked at being able to try and use genetics, that's the key question, because a woman in her 30s versus a woman in her 45 have the exact same genetics, and actually you can't tell at that time to be able to predict the age of the menopause. So the largest genetic studies have been done with more than 70,000 people, and this is collaborations, using genome-linked association studies. Essentially, you can only get to about 10% of the population variance. So though it might be interesting to
जावचे ना 300-400 रुपये जातले
for me, we'd be able to explain for an individual what the chances are of them. You could be using that same test as a baby as you could be at 45, but not taking into account how many follicles have got left.
बाकीचे गुळी असं ते ताका चालू दवरूं जाय
So what's striking though is a lot of those genetic variations have been associated with a lower AMH, and there's a new recent GWAS of AMH bringing all.
कम सो ह्यो 2 गुळी आसतल्यो मगो टॅमॉक्सिफॅन म्हणून आसतली गुळी ही एक सकाळी एक रातची घेवपाची हां आणि इस्ट्रोफट म्हणटा ती एक सकाळी एक दनपार एक रातची
Is not people who
आणि म्हाका येवन मागीर
can't do transvaginal scans and can't easily get an anthropology.
ओके
Oncologists, the whole medical spectrum who can't do
Okay.
vaginal scanning. So we know that
कितें जालें
developed this using 800 outlined to be able to show what their AMH is, and we can have these in package inserts in terms of the nano. And what you essentially would go from one to the other, you multiply by 7.
पळोवया मगो गुळयो घे आनी पळय म्हाका येवन दाखय मागीर हां
After 5-year-old, about 15 pico.
एक सकाळी एक दनपार एक रातची कितें
That's the European population, but does that apply to other
म्हणटा ती गुळी आज आनी फाल्यां
ethnicities?
आंगान भितर घाल रातची न्हिदूंक वता आसतना हां आनी ओविलॉक म्हणटा ती गुळयो आयच्यान डेली एक एक रातची घेवपाची कळ्ळें आनी म्हाका मागीर सोमारा हांगा परत येवन दाखय ओके
बेस्ट आहे मी
काय ना आणि फिडिंग बी करता मगो
So, in terms of
ब्लिडिंगच जाता असे सकाळची साणे मारतात सारखे ब्लिडिंग चालू असताना
दुखता चढ
is 49. So we've just done a large Europeans, and what I want to show you here is you can see that the orange dots are illustrated by the Chinese population and contrast the green ones to European, but essentially they're substantially lower throughout their life. So
आणि टॅक्सिन एझेड दिसाक
if they're older than 25, there's
ही 5 दिवस
quite a marked divergence. And you can see that that divergence actually increases as women get older. So for any given age,
आणि मसाला
and you measure an age
कळे
lower than that you see in a European population. So one of the questions that ovarian reserve testing, and the answer to that is absolutely not. You definitely know for either ovarian response for IVF, and you use a centile-based approach. You can see here that if they're on the 5th centile for a Chinese population, your AMA for your European population, and for the Chinese population, and therefore they will do badly both in terms of IVF and also in terms of going through the menopause earlier.
दाखवायचं
म्हणजे 20 तारखेक म्हणजे सोपांक जाय गुळयो काय
19 तारखेक सोप
सगळे सोपता
From, ovarian reserve testing. What you should be doing is thinking,
चालू असं ते चालू
okay, I'm interested in the outcome.
बरे ओके 20 तारखेक येता
Menopause, and it's 49 for Chinese, but you need to take that into account when it says that someone's got an average AMH. That just means they're going to go through the menopause at an average age for that country. So you've heard about, that we know that smoking, goes through, kills follicles, and people who smoke go through the menopause earlier. And you can see the effect on the ovary here of sham smoking mice versus smoking mice and a reduction of that. And again, at any given age, people who smoke will have lower AMHs. So that all is consistent, just like the Chinese population where it's a couple of years earlier for menopause, the same applies to smokers. It's a couple of years earlier. We also know that chronic disease affects follicular genesis, and actually they go through the menopause earlier as well. So you have lower AMH values in women with lupus, and again, people who've had renal disease have lower AMH and have an earlier age of menopause. So things that have an adverse impact on your ovarian reserve and are associated with a lower age of menopause all have associated with a lower AMH at any given point across the lifespan. So how can you bring all that together to be able to actually predict, age at menopause? Well, the gold standard trying to predict when you go through the menopause was ask your mum. Because there was quite strong genetic concordance, about 70% between offsprings and their mothers, you could just say, when did you go through that? But obviously there's a large population of mothers who've never had a hysterectomy and therefore never had a natural age at menopause to be able to tell their daughters. And actually, can you do even better than that? Well, the data suggests that even asking your mum, by knowing you're an AMH, you can do better than that. So this is just to show you some data. This is one of the very first papers that came out, a very small study, 257 from the Broekmans group in Utrecht. And essentially what it showed was that those women who got very low AMH here, shown by the red lines, as compared to those with very high AMHs at the other end, went through the menopause in an earlier basis. And you can see that when they follow these women up, that there was a shifting across those menopause centiles. So this is, you can imagine, you've got a very low AMH at age 25, you're at increased risk of having an earlier menopause by several years. But that's not quite the same as trying to predict. That's just saying you're at risk of that. When you look, I say, at the chance of them being able to predict, you can see here there's quite wide distribution across those, from all the way from 35 all the way out to 55 for that lowest 5th percentile. So trying to predict 20 years in advance is very difficult. What it's much more like better at doing is trying to predict whether or not it's going to happen within the next few years. And that's, you can see that here, that in terms of the probability of going through that menopause, depending on whether or not you're undetectable AMHs, obviously you've got a very low ovarian reserve, and actually what will happen is that people will try to preserve that. But if you're older and there's an interaction there and you've got a low AMH, what you'll see is that there's a very high probability. You can see that at the top here, at least if you're 50 or 48 or 46, that's when the test is becoming really useful for being able to predict, yes, you're going to go through that menopause at an early, within the next few years. But I'll come back and show you data that says that we can individualize that even more. So if you had one measurement, did having subsequent measurements be useful? If you measured it in a 23-year-old or a 25-year-old, does measuring again in 26 or 27? Well, the suggestion is that actually, when you look at multiple models and looking at how it changes across those timeframes, the reality is that very early measurements is probably adequate. You can see here measuring an age at 20 or 25 adds value, but going beyond that, or looking at the difference or trying to work out its trajectory of decline, doesn't add a huge amount of value. And so, but absolutely, you can now say to people at age 20 and 25, you've got a low AMH, actually you're at high risk of having an earlier menopause. So what about those clinical scenarios? I gave you 5 specific scenarios at the beginning. So Susan, was a 35-year-old whose mum and sister had POI, and she's wondering whether or not she would get it. And we didn't have good data. I've shown you some of those longitudinal studies that suggest if you measure Susan's AMH and it was low, you would think she would be at risk of that. But now, using Nurses' Health study, what there has been is a follow-up of a whole load of women who did subsequently develop POI. And by measuring their AMH and comparing it to the health controls, that's exactly what they see. That for each 0.1 nanograms per mil lower, or 0.7 picomoles lower, was a 14% increase in the risk of them having an early menopause. But you think, well, that's not a huge amount, 0.1 or 14%, but you can imagine that actually what we're talking about is going from 15 picomoles per litre or 2 nanograms per mil down to actually undetectable levels. That's what, or 1 nanogram per mil. So she's got half the amount she should have had, or 7 picomoles per litre. It's half, and therefore it's a huge effect that she's getting because it's multiplied by 7. So if she's going from 1 nanogram down, from 2 nanograms down to 1 nanogram, that is tenfold. She's got 140-fold increased risk of having an early menopause. So I think we can use it certainly for those for thinking about have you got risk of POI. The second scenario we mentioned briefly was Julian. He was 32. So for whichever trajectory she's on, she's going to have her chemotherapy and then have a hit with that and look and have to take her decline in her ovarian reserve as those follicles are killed off by her chemotherapy. The chemotherapy will then stop and she'll then have potentially a recovery period beyond that. But what you can see here is that there's a very threshold for premature ovarian insufficiency. And if she has a good ovarian reserve, although she's going to take a hit, she's going to come out of that and then beyond and be able to go beyond that in terms of thinking about where she is. In contrast, if she's got a very low ovarian reserve, illustrated by the red line, she's never going to be able to recover from that, and she's not going to have any follicles and actually have premature ovarian insufficiency. So though this is a concept, is there any data to essentially support that? And the answer is absolutely there is now. My colleague Richard Anderson from University of Edinburgh looked at a prospective cohort of women with breast cancer undergoing treatment. And what he was interested in was for those who developed premature ovarian insufficiency, and that was defined by those who had amenorrhea plus an FSH above 25 international units at 2 years. And you can see here the estradiol for the women who did develop, the controls are actually in the red here. They were healthy, didn't develop POI, in contrast to the blues who did do that. And you can, as you can imagine, the estradiol reduced over that time period. In contrast, the FSH is increased, as you'd expect, given that it would be menopausal, it's going to be above 25. And the AMH is also, decreased over that time period. So although those women who subsequently developed premature ovarian insufficiency did have lower AMHs at the baseline, what was very striking was that they had undetectable AMHs, at the end of treatment, and again at 12 months, and again at 24 months. So it was the end of treatment samples that become particularly of interest. And what he showed was that an undetectable AMH at the end of treatment was, diagnostic of premature ovarian insufficiency. The diagnostic odds ratio was 42.8. Normally when we think of diagnostic odds ratios, anything above 10 is clinically useful. So 42.8 had a huge effect. The advantage is for oncologists is that they can then start to think about changing the adjuvant therapy that they would give to young women. Because if they know that that woman is menopausal, they would no longer be thinking about giving tamoxifen, they'd potentially be thinking about giving an aromatase inhibitor because of the improved survival benefits with that as compared to tamoxifen. So actually being accurately able to diagnose whether or not that woman has premature ovarian insufficiency at the end of the chemotherapy has huge benefits for the oncologists. And that's why we can help engage with them and inform them of what we think is happening with our patients. We don't need to wait for 12 months and say whether or not this woman has got it. We can say, actually, we predict that this woman does have that, and you can change your treatments as a consequence of that. The next scenario we talked briefly about was Mary, who was interested in how much longer is she going to have those irregular periods for. She's already, having some flushing, and she's wondering whether or not she's continuing. Well, we know that serum FSH is going to rise, and it will rise in conjunction with that final menstrual period, and then it will continue to rise beyond that final menstrual period, and then eventually start to come back down again. The serum estradiol fluctuates and has, more or less stays the same until after the menopause. But you can see here the correlation coefficients between these two hormones and the time to the final menstrual period. Estradiol not predictive at all, and serum FSH has some predictability with a variability of 0.04. Now, when you compare that to what you see with AMH, AMH is substantially better using, 0.52. And this is an American study, the SWAN study, where they followed women up and have looked at them going through the menopause, and they used the Labs Pico AMH assay, which is actually still a manual ELISA. It's a sensitive ELISA, very similar sensitivity to you see with the Roche assay, but it is, I'd say, a manual assay, but that has enabled them to be able to have that approved by the FDA in terms of being able to utilize the menopause. But what I'll show you is some exciting new data that's been used using the Roche assay, and it shows that we can use it for the exact same purpose. And what it was suggesting was that essentially if you've got lower limits of the sensitivity, and the assay can't differentiate here between 0.01 or 0.002 is essentially the same, it could predict that you were essentially going to be going through the menopause within a specific number of months. And you can see here, so essentially you have undetectable AMH. The reality is that most people will be going through the menopause within 2 years, say 26 or 27 months at that point. But at least half of them will be within the next 6 months. So that's still predicting about whether or not it is. That's not the same as trying to diagnose. I'll come on to that in just a minute. But what they recognised within that SWAN study was that actually it became much more accurate depending on how old the woman was. As we saw earlier, the older the woman she is, the more accurate AMH is in terms of predict when you're going to have that final menstrual period, within being able to predict within just a few months, plus or minus, as to when that's going to be the case. So we can be able to do that, and essentially what we're thinking about is, if you're thinking about Mary, are you just going to use one test? Will you just use AMH on its own, or are you likely to be able to use a combination of biomarkers? Because you can measure that AMH on the same blood test that will measure your FSH and your LH and your estradiol. And clinically, that's probably what we would do, is we would combine these to be able to come up with a picture for Mary. We wouldn't just be thinking on relying on one test.
Okay. 3 times. Okay.
Predict the age of the menopause is that knowing what her woman's FSH actually helps here. And that's because FSH trajectories do change depending on whether or not someone's going to go through the menopause early or going through it late. And you can see these 2 solid lines here as to when women are going through the menopause. But you can see those who went through the menopause earlier are showing that the FSH rises go up proportionately. And in terms of that, you can see that they will rise exponentially as compared to those who are going through the later menopause, where the FSH goes up slightly later. And that's not surprising. That's what you'll see clinically when you see someone who's in their 40s and actually already has FSHs of 17 or 18 picomoles. You're going to be much more worried about them than you would do if she's 43 and she has, an FSH of 4 international units. It makes perfect sense, and it's what we see clinically. So can you combine that with the markers? And we know that in terms of prediction of menopause, actually you can do that. Not only can you think about using your AMH and that FSH, but also, do they smoke? We know that smoking is a risk factor for early menopause. So actually they should be going through it earlier as well. And if you combine those early FSH rises with the AMH, with the smoking, you get better predictions than if you do not and just using one of these in isolation. So what about confirming the diagnosis of the menopause? One of the key things there was that NICE, the National Institute of Clinical Excellence in the UK, looked at all the tests. And this is just a summary of what they came up with, because this comes back to this. Very well. But the reason for that was when they looked at all the tests that were available to them, and I realise it's very small print here, was at the left-hand side. You can see it's into the green where it's a useful test. You can see that it was the fact that the woman was over 60. And I would suggest to you clinically that's a complete nonsense, because you already know that the woman was likely to be menopausal given that she's 60. But the only other marker that was useful was this hormonal algorithm, which you can see on the right-hand side of there. But because that was one small study that was done prior to 2013, which is the systematic review that they did for this, actually they didn't place any weight on that. But the field has moved on quite dramatically since then. So this is the new data that's just come out we're just working on this for publication just now. So this is using 3,367 women who were followed up across the menopause transition. So they were followed up for over a period of up to 16 years. And what you can see is we did over 4 clinics, we did multiple repeat hormone measurements. On the 2 y-axes, on the left-hand side, you've got international units. So we've got SHBG, FSH, demonstrated by the blue line, and LH demonstrated by the green line. And then on the other y-axis, we've got AMH in terms of mean in nanograms per mil. And what you can see is that there's this dramatic decline in AMH well in advance of the menstrual period, final menstrual period, so in advance of the menopause. and then it stays undetectable all the way out to 16 years after that menopause. In contrast, then FSH goes up well above that diagnostic threshold of 25, all the way up to about 70, and then subsequently slowly declines thereafter. But what is critical is the fact that you can see that AMH is the first hormone to change, and it becomes undetectable before you hit any diagnostic threshold for FSH or LH.
हाँ
So just to conclude,
हाँ
then, what I would suggest is that present genetics don't explain adequate variance age of the menopause. We can measure AMH, and Professor Belasco very
तो अभी क्या हो
clearly
रहा है आपको?
indicated as to why clinical interpretation is critical, as it reflects follicular genesis, and factors which will impact on that will impact on an AMH value, particularly in young women.
Okay. कुछ अभी दर्द
If you measure an AMH in a young woman, it is associated with the age of natural menopause, but it has quite wide confidence intervals over that. And that's not surprising if you're measuring something at 25 and trying to predict something 25 years later, that you can put some numbers on it, but it will be slightly less accurate. It is, however, absolutely concerning for fertility and reproductive lifespan. We know women with undetectable AMH is going to be at risk of premature ovarian insufficiency, and therefore you may be thinking, actually, you need to think about that in terms of your family lifespan. We know that undetectable AMH post-chemotherapy now predicts premature ovarian insufficiency and is diagnostic of that with an odds ratio of at least 42, and that's now been validated in some other work. So it's being able to change what the oncologists do and how they actually guide their patients as well. And then lastly, the FDA has now approved AMH for determination of the menopause, but it's not in isolation, it's in conjunction with other clinical laboratory markers. And that's exactly how we should work on a clinical basis. We don't need to rely on one test, it's just part of the armamentarium that we've got available to us. So we measure AMH and we do it on the same blood sample with FSH and LH. And what you can see, but hopefully I'm showing you from the new ALSPAC data, is that actually if AMH is undetectable, we know that woman's going to go through the menopause. And if she's got that with detectable FSH and it's not too high, actually it's pending and it's going to be within the next 1 or 2 years. So thank you very much for your attention. We've got a couple of questions. Hopefully a free and answer session. So, okay, so you can see here which hormone change first in advance of the menopause signals an impending menopause. FSH rises above 25 international units, AMH declines to undetectable levels, estrogen declines to undetectable levels, or LH increases to above 20 international units. If you can say which one you think is the best answer, that would be great. Okay. So thanks very much. So essentially, what is AMH declines to undetectable levels is actually the first change that you can see. And that's because of, it's in advance of the menopause. And that's what I was trying to show with this slide here, that actually you can see that AMH falls, dramatically before you get to, the FSH is rising above 25. So FSH, above 25 absolutely is diagnostic of menopause, but you can see there, you've got this precipitous decline in AMH in advance of being able to get there. So we just do the second question. What are the implications of an undetectable AMH 9 months after completion of chemotherapy in a 30-year-old? And these are different possible clinical diagnoses you can come up with. 1, she has hypogonadotrophic hypogonadism. 2, she has PCOS, and that's why she's got undetectable AMH or irregular cycles. She's likely to recommence her combined oral contraceptive pill. 4, she has premature ovarian insufficiency. Or 5, she's had a natural menopause. The key being a natural menopause there.
पेशाब करते समय कुछ
So
तकलीफ
she could, once again, select the preferred answer.
अल्कानिल करके सिरप आएगा, वो आपको मैंने एक ओके अल्कानिल सिरप आएगा, ये दिन में 3 बार लेना पानी में डाल के, हाँ। और ये मलम आएगा कीटो बी ऑइंटमेंट, ये नीचे लगा देना, ओके, हाँ।
And yeah, absolutely. So she has premature ovarian insufficiency. She's got an undetectable AMH as a consequence of her chemotherapy, and that's what we were talking about in terms of cancer being able to do that. If she had, hypogonadotrophic hypogonadism, she'd probably still have a detectable AMH. PCOS, the AMH would be super high and it would be, elevated for that. She's not had a natural menopause because she's 30, so it would always be iatrogenic or, premature ovarian insufficiency.
Yes.
And she's unlikely to commence the pill because, again, it wouldn't suppress it to that extent. And then the final question is really to try and say which hormonal changes are suggestive of a natural menopause. So it can be either a normal FSH with an elevated LH and a normal AMH,
or
a low FSH, a low LH, or a low AMH, a high FSH, a low LH, and a normal AMH, a high FSH, a high LH, and a low AMH, or a low FSH, low LH, and a normal AMH. And I'm sorry for the combination of these, but that's really what we look at when we get these clinical results back, is which pattern do they sit in. It's not just one test we're looking at as also, it'll be all 3, and you can choose which one hormone pattern you'd like.
24 hours
would be suggestive that the woman, has gone through a natural menopause.
Yes. सांग.
Great.
चलो.
Many thanks for all those putting answers in. And yeah, absolutely right. The vast majority have got that correct. It's be a high FSH, a high LH, and a low AMH. And anything that was suggestive of a normal AMH wouldn't be consistent with that. Obviously, number 3 there was the second most popular answer. You've got a high FSH and a low LH. But both of those are going to be elevated well above 25 international units for them to be consistent with the menopause, and that AMH will be undetectable. So thank you very much for your attention. We're now going to pass over to a more general question and answer, where you can either text us the questions or I'll pass back to Professor Prof.
Many thanks, Professor Nelson, for sharing the valuable information and insight. I think you emphasized about the ethnic origin and the variation of anti-melanin hormones, especially in China. But I think in India, we are almost the same like China, but I'm sure the data has to be analyzed some more. And you also beautifully emphasized about the role of how the AMH goes down in cancer patients and, of course, immunologically connected diseases as well. And I think both the speakers, Professor Velasco and Professor Nelson, have emphasized how smoking can reduce AMH. I think we are all duty bound to look after the young girls and the adolescent girls and probably tell them not to smoke. So I think we have question and answers, but we have to, there are about few questions, but I would like to take up the first question to Professor Velasco. The question to you is, are there statistics on the general rate of decline of anti-Mullerian hormone concerned with age, 30s to 40? What is considered acceptable? Professor Velasco.
Well, thank you. Yes, I think that we have today plenty of data, and I think my dear colleague, Professor Nelson, clearly explained how there's a normal decline, and this normal decline has to be adjusted for ethnicity. We have seen that maybe in the Southeast Asia, the decline is a bit quicker, and we saw also a few years ago how AMH and AFC declines about 5 or 6 years before than in Caucasian women. And this data is interesting to have it in the outpatient office, because we can discuss with the patient what are the AMH values that we get, what is the exposure that she's to maybe smoking, hormones, surgery, chemotherapy, and then plot this value with the decline that we know within the 5 to 95th percentile. And with that, we can counsel her much more individualized. So I think today it cannot be just a guess. I think we have data that we can use, and this data is going to help us to deliver a message that would be useful for the patient.
Thank you. I think you also published the data along with some Indian authors regarding the same. And I agree with you that we need to be a little more careful in this kind of continent where there is a reduction of AMH much before the Europe. Another question to you, Professor Velasco. In terms of fertility preservation, are there any principle when you might perform and then repeat AMH as surveillance to time oocyte preservation?
Well, that's a very good question, because fertility preservation to postpone maternity is still a little bit controversial, even though we are strong supporters, but I know across the world there's different views on this. So the way we present this to our patients is that if we consider that the patient is at risk of POI and she has a short time to be pregnant, I mean, that's difficult to estimate, of course, as we have heard, but if we consider that she is not planning to have a family in the next 3 to 5 years, we suggest her to freeze the oocytes. If she is still hesitant, we should usually reevaluate the AMH in 6 to 12 months, not before that, because it's not going to change much. And in 6 to 12 months, we can have an estimate of how quick is this decline. But my suggestion is not to wait 1 more year, because if you have a patient that you're considering oocyte freezing because she wants to postpone maternity and she waits 1 additional year, the expectations for her to respond to the stimulation are going to be even lower. So I think with the data of the AMH, AFC, age, and of course patient desire, a patient plans to have a family, I think we have to make a decision in 2 to 3 months. And I think that's important, because if she decides not to have a family, or whether not to do anything, just wait, at least her expectations will be as close to reality as possible. But most of the times what we suggest is once we have the data, once we have the patient at risk of POI, we suggest her to go through oocyte freezing, because it's quick, it's not very complicated, it's not very expensive, and I know it's not legal in all the countries, but I think it's at least it's a nice way to put the pressure out of the time. And then once she has these oocytes frozen, that will not guarantee a baby, of course, at least going to release the pressure on her, and then she may have the time to find a partner and maybe establish a family in a natural way. Maybe she will never use and never come back for the frozen eggs, but I think it's a nice way to help her to make a decision.
Thank you so much for emphasizing the importance of AMH and the future plan for this young girl who has a low AMH. The next question is to Professor Nelson. Why do women with BRCA mutation have low anti-Mullerian hormone?
So, there's been a couple of different studies have looked at BRCA. Some have suggested that there is an association with having lower AMH values, and others have not found an association, and suggested that they have equivalent ovarian reserve. So I think that it's not subsequently clear. So because it's not clear, I'm not sure of the mechanism for that underlying why that would be the case. I think the second part of the question was, do you need to screen all women, who have got a low AMH for BRCA? And the answer is no, I wouldn't do that. I think there's much better international guidelines for when you should be screening for BRCA rather than using AMH as the kind of pathway into that. Because the AMH is a blood test, and if it's fifth centile, 5% of the population will be that. So I wouldn't use AMH to drive your BRCA testing. I would use your cancer history to drive your BRCA testing rather than the other way around.
I think it's absolutely right, because a woman with cancer, especially when they are referred to us for fertility preservation, we know that their AMH is low, and we need to really increase the gonadotropin level in them. So I think these pre-cancer treatment patients must have an AMH, and they'll be low. But what I understand by reading the literature is it's all connected to telomerase in the gene. And the telomerase basically is, something with the genes where they have a repair capability. And if telomerase is deficient, there's something going to happen with these kind of AMH, and they go down. Probably they go down. That's probably the explanation. But I think we have one question to Professor Nelson again. The question is, when talking about so much of psychological impact, what is the psychological counseling, or does it really play a lot of role in the first consultation itself?
So I think it depends what was the driver for that consultation. Why did they come into your clinic in the first instance? Where on what question are they wanting to have addressed? And I think if we were trying to give them, bad news, for example, they've got a devastating diagnosis of, we've just confirmed that they've got premature ovarian insufficiency. Absolutely, I think the psychological support that they're then going to get from that diagnosis is critical. And because we're telling them, we essentially have told them a devastating diagnosis, and it's how do they manage that subsequently. So we would have, certainly within UK, they'll be getting, psychological counselling support if they can opt into that, though. It's not compulsory. And then they'll also kind of give advice on what the various charities are to facilitate peer-to-peer support mechanisms. And then we'll be seeing them back subsequent to that, be able to think about, how do we manage this and, address any questions. So I think it's very much a multidisciplinary team, and psychological support would just be part of that. Yeah.
Absolutely. I think we need to do a comprehensive care for these kind of patients and adding on psychological support. Another question to Professor Belasco. What is the effect of diabetes on anti-Mullerian hormone?
Well, that's a good question, because as you have seen, there are plenty of conditions that could affect the general condition of the patient. And we mentioned some of the diseases like Crohn's disease and some others that we didn't go through them. But the problem with a metabolic disturbance and even a metabolic syndrome is that it may compromise also ovarian health. So as we know, glucose disturbance or levels of glucose that are not within normal ranges, it's not a good thing for the vessels. It's toxic for the vessels, as we know, for many different reasons. And could be that also ovarian vascularization could be compromised in these women. This data showing an association, and probably the direct biological influence hasn't been clearly investigated, but I could speculate that maybe it's a compromise of this vessel health or vascular health in the ovarian tissue that may compromise the health of the primordial follicle pool.
Thank you very much. It comes to the end of the webinar now. We have finished the time. We thank Professor Belasco, Professor Nelson, for their wonderful lectures and the participation. Many thanks to the audience for attending the webinar. We hope that you found the webinar informative and worthwhile. Please spend a little bit time, send us a feedback onto the webinar. The feedback is on the screen, you can do that. And I'm sure we'll see you in the next live webinar sometime. Thank you so much, Professor Velasco. Thank you, Professor Nelson, for being with us. And I'm so glad to be moderating this session along with you great guys. And I'm feeling very happy about it. Thank you.